Welcome to the Deep Dive. Today we're cutting through the noise to understand a topic that touches every patient, yet often remains unspoken. Human sexuality in the context of psychiatric mental health nursing.
Yeah, it's a really important one.
We're extracting key insights from Varkarolis's Foundations of Psychiatric Mental Health Nursing, specifically the 8th edition. We'll be focusing on sexual dysfunction, gender dysphoria, and paraphilic disorders.
That's right. And our mission really is to unpack these complex concepts, not just academically, but for direct application in your nursing practice.
Right.
We'll explore assessment, therapeutic communication, the different disorders, psychopharmacology, and evidence-based interventions. And we'll try to keep the language clear, relevant for you, our future nursing professionals.
Think of this as your essential guide, providing holistic, patient-centered care, navigating those tricky ethical bits, and even becoming a powerful advocate for your patients. We'll clarify diagnostic criteria, break down terminology, highlight safety measures, and connect everything back to what you'll actually encounter in clinical practice and, yes, on your NCLEX exams. Okay, let's unpack this. So let's begin where the textbook does. With this observation that while nurses are often comfortable with very intimate physical assessments, sexuality itself remains a source of discomfort for many. Why is tackling this discomfort so vital for, holistic patient care?
Well, what's fascinating here and really central is that addressing sexuality isn't just some add-on. It's absolutely integral to holistic care.
Okay.
Patients genuinely want to know how their medications or treatments will affect their relationships, their sex lives. It's on their minds.
Makes sense.
So when nurses open this conversation, they normalize these deeply personal issues. They can clarify values, maybe dispel some myths, provide vital education. It's really about reducing suffering and improving overall health in a profound way.
The chapter then lays out the 4 phases of the normal sexual response cycle. This goes back to Masters and Johnson in 1966, right?
That's the classic framework, yes. Desire, excitement, orgasm, and resolution.
Can you walk us through them? Why do nurses need to grasp these?
Absolutely. So, desire. This isn't just biological urges. It also involves psychological motives, like the choice to connect and those deeply ingrained values we all have, familial, religious, cultural beliefs.
Right.
For nurses, understanding that low desire isn't automatically a problem unless it's causing distress. That's key. And hormones like testosterone definitely play a role here.
Okay, phase 2.
Excitement. This is where sexual tension builds. You see physiological changes, penile erection, vaginal lubrication. If this phase doesn't happen when it, should, it points to an inhibition.
Got it then.
Orgasm. Reached at high levels of sexual tension often needs some kind of stimulation, direct or indirect. The insight here is recognizing differences, like the male refractory period.
That time after ejaculation.
Exactly. When another erection or orgasm isn't possible for a bit, it varies with age, versus women's potential for multiple orgasms.
And finally,
resolution. Sexual tension drops back to baseline. Those physiological changes disappear. This can be, a pleasant afterglow, or for some, maybe an uncomfortable feeling of emotional exposure. Understanding these phases helps nurses pinpoint where a patient might be hitting a roadblock.
before we get into the dysfunctions themselves, there's a really critical ethical and cultural point in the source: female genital mutilation, FGM. Can you describe what that entails and its impact?
Yes, and this is incredibly important. FGM is the surgical altering of female sexual organs for non-medical reasons. It's condemned globally by the WHO, the UN.
And it affects millions.
Millions of females worldwide, yes. It includes various procedures. Type 1 is partial clitoris removal. Type 2 includes the labia minora. Type 3, infibulation, is the most severe external genitalia removed, stitched together.
It's hard to even comprehend.
It is. And this practice, often done ritualistically, maybe in unhygienic conditions, leads to severe lifelong health issues. Chronic pain, infections, UTIs, cysts, infertility, devastating childbirth complications, altered sexual response, painful intercourse.
So for nurses, the challenge is huge.
It's a profound ethical tightrope. How do you provide compassionate care for someone suffering because of a deeply ingrained cultural practice? Without judgment, but still upholding safety and human rights, it really demands building deep trust and significant cultural understanding.
Okay, now let's move into sexual dysfunction itself. How is it defined?
Yeah.
Classified. What's the first step for nurses?
Right. Sexual dysfunction involves disturbances in those phases we talked about: desire, excitement, orgasm, or actual pain during intercourse, something that prevents or reduces enjoyment.
And the first step?
Crucially, Before jumping to psychological factors, a thorough physical assessment, maybe including lab work, is needed. Rule out physiological causes first.
Makes sense. And the classifications.
The DSM-5 outlines 7 major classes. Things like male hypoactive sexual desire disorder, female sexual interest arousal disorder,
Erectile disorder.
right, female orgasmic disorder, delayed ejaculation, premature ejaculation, and then genitopelvic pain penetration disorder.
The source also clarifies the difference between asexuality and celibacy. Important distinction.
Yes, very. Asexuality is a distinct sexual orientation. It means someone experiences little or no sexual attraction. They might still want physical intimacy, like cuddling, but not necessarily sexual activity.
Whereas celibacy.
Celibacy is a conscious choice, choosing to abstain from sex, even if you do feel sexual desire, different things entirely.
Could you give us a quick highlight of the clinical picture for maybe a couple of these common dysfunctions?
Sure. Let's take male hypoactive sexual desire. That's a deficiency or absence of sexual desire or fantasies, often linked to low testosterone, maybe depression.
And for women?
Female sexual interest arousal disorder. Similar idea, reduced interest or arousal, causing distress. It's influenced by a mix of neurobiological, hormonal, and psychosocial factors.
Okay. What about erectile disorder?
That's the consistent failure to get or keep an erection sufficient for activity. Its prevalence definitely increases with age.
And female orgasmic disorder?
A recurrent delay in or absence of orgasm after normal excitement, often lifelong. Psychological factors like fear of losing control can play a role.
Then there's the pain one. Genitopelvic pain penetration disorder.
Right. This used to be called dyspareunia and vaginismus. It interferes with penetration, could be penile insertion, even a speculum exam because of pain and involuntary muscle tightening.
And the fear can make it worse.
Absolutely. The Jessica vignette in the chapter illustrates this perfectly. A new mom suddenly has severe pain during intercourse, creates huge distress for both her and her partner, shows how that fear cycle can really compound the problem.
So, wrapping up this section for nursing students listening, what are the key takeaways, the common threads here?
Well, it really highlights the sheer range of factors. Biological, psychological, interpersonal, even substance-induced things can all lead to sexual dysfunction. And the epidemiology is notable. These dysfunctions are actually more common in women, around 40–45%, compared to 20–30% in men.
That's significant.
It is. And comorbidities are common things like schizophrenia, depression, personality disorders, past sexual trauma, obesity, even a sedentary lifestyle. It just hammers home the need for a truly holistic approach. As nurses, you're connecting dots across the whole patient picture.
Okay, this is where it gets really practical for our nursing students, applying the nursing process. Starting with assessment for sexual dysfunction, especially when patients might be, hesitant to talk about it.
Assessment is absolutely key, yeah. It involves both subjective, what the patient tells you, and objective data. Nurses need to be really attuned to how patients might cue them about sexual concerns, even without saying it directly.
Like nonverbal cues.
Exactly. Blushing, fidgeting, maybe even overly sexual behaviors, or verbal cues making sexual jokes, asking questions that seem a bit off, or maybe expressing worries about relationships or how meds are affecting them.
So it's about reading between the lines sometimes.
Very much so. The real aha moment here isn't just listing dysfunctions, it's realizing that maybe our most vital role as nurses is just creating that safe, non-judgmental space. A place where patients feel they can voice these incredibly personal concerns that often gets missed in busy clinical settings.
And what about the nurse's own feelings? This can be awkward for the provider, too. Self-assessment seems important.
Oh, absolutely crucial. A nurse's own discomfort, maybe from lack of training, maybe inexperience, personal biases can be a real barrier.
So what does the book advise?
Using a professional tone, first off, and clearly explaining why you're asking these personal questions. Using facilitative statements can help too. Things like, many people worry about feeling, or some people prescribed this medication find it difficult to achieve an erection. Have you had this problem?
That normalizes it.
Exactly. It makes it less awkward for the patient. Remember, assessing sexuality is just part of good holistic nursing care. Your role is to help patients cope with illness and treatment, all aspects of it.
Okay, so once assessed, how do we move to nursing diagnosis and setting outcomes in this sensitive area?
Common nursing diagnoses might be sexual dysfunction, meaning a change in sexual function that leads to dissatisfaction, or perhaps ineffective sexuality pattern, which reflects concerns about one's own sexuality, maybe due to lack of a partner, orientation conflicts, relationship issues, or just not enough knowledge.
And the goals, the outcomes.
We'd look for things like the patient attains sexual arousal, expresses ability to be intimate, exhibits clear sense of sexual orientation, or reports healthy intimate relationships. It's really about helping the patient achieve a better quality of life and self-acceptance.
Right. Moving on to implementation.
Yeah.
What are the key nursing interventions here?
Well, building trust and ensuring privacy are foundational. Then, discussing how illness or meds might affect sexuality. Correcting myths is a big one, too.
Oh yeah, there are plenty of those.
Definitely. Reassuring patients about healthy practices, including partners in discussions when appropriate, and critically, knowing when to refer out to specialists like sex therapists.
And the pharmacological side, you mentioned it's growing.
It is, and interestingly, mostly focused on men, even though women have higher rates of dysfunction. For men, you've got the PDE5 inhibitors sildenafil, Viagra, tadalafil, Cialis, vardenafil, Levitra, avenafil, Stendra. Also things like alprostadil, testosterone therapy.
And for women.
The book mentions flibanserin, or AD. And for premature ejaculation, sometimes SSRIs or topical anesthetics are used. The key is knowing these options exist to target specific physiological issues.
What about managing those really common antidepressant-induced sexual side effects? That's a huge issue for patients. How do nurses help navigate that?
Nurses play a huge role here, helping patients weigh the pros and cons of their treatment. Strategies include, well, sometimes just waiting to see if the side effects diminish over a few weeks, or maybe reducing the dose slightly, if possible. Timing the medication differently relative to sexual activity might help. For men, sometimes using those PDE5 inhibitors can counteract the effect, or ultimately, maybe switching to an antidepressant known to have fewer sexual side effects, like mirtazapine or bupropion. It's all about patient education and collaborative problem solving.
And beyond meds, what about psychosocial approaches? What should nurses know about?
Individual and couples therapy are very common, and there are specific techniques nurses might hear about or refer patients for.
Like,
Sensate focus. That's a therapeutic technique where couples gradually reintroduce touching and intimacy, but without the pressure of intercourse initially. It's about focusing on pleasure, rebuilding connection, reducing anxiety.
interesting. What else?
Behavioral therapy, often used alongside meds, especially for premature ejaculation. Systematic desensitization, which pairs relaxation techniques with thinking about anxiety-provoking sexual situations. And masturbation training, which can be especially helpful for women who've never experienced orgasm, helping them learn about their own bodies and responses.
The chapter also mentions a study on sexting among college students.
Mhm.
What are the takeaways for nurses from that, especially with social media being so pervasive?
Right. That study found a big chunk of undergrads, like 80% received, 67% sent sex, often driven by positive expectations, like hoping to hook up.
But downsides too.
Negative outcomes were actually rare, but the most common one was sex being spread to others without consent. So for nurses, it means staying current, knowing about trends like sexting, and being ready to help young people cope with the potential stressors of social media around these really sensitive topics of sexuality and intimacy. It's about meeting patients where they are, understanding their world.
And the Maria vignette, the 67-year-old widow considering marriage, worried about her sexuality. What does that case highlight?
Marie's case is great because it shows that nurses, especially advanced practice nurses, can really open up these conversations with older adults, too. They can explore physiological reasons for low interest, like hormonal changes, postmenopause, and intervene effectively, maybe with small doses of testosterone in her case.
So it reminds us sexual health is lifelong.
Exactly. Patients, regardless of age, need support and open communication. It powerfully underscores that our scope of care covers the entire lifespan.
Finally, for this section, how do we evaluate if the care we provided for sexual dysfunction was effective?
Evaluation really centers on the patient's perspective. Have they achieved a level of control and personal satisfaction that works for them? Do they accept the dysfunction as part of their experience but not defining it? Are negative attitudes about sex no longer a major problem? It's about their sense of well-being.
Okay, let's shift gears now. Broaden the perspective from individual dysfunctions to gender identity itself. We're diving into gender dysphoria, a topic that's seen, well, quite significant evolution in understanding. What's the clinical picture here?
Right. So gender identity, that intrinsic sense of being male or female, usually forms pretty early, by age 3 or so. Gender dysphoria happens when someone's biological sex is different from their deeply felt gender identity.
Causing distress.
Yes, significant feelings of unease, discomfort. It's often described using phrases like a woman trapped in a man's body or vice versa.
And the big change the source highlights.
The crucial insight here, and it's a major shift emphasized in the source, is that gender dysphoria is no longer classified as a psychiatric disorder.
That feels really important.
It is. It's not just changing a label. It's a fundamental reframing. Healthcare is moving away from trying to fix something towards supporting an individual's authentic identity. It's about understanding human variation.
So, with this shift in perspective, what symptoms might children, adolescents, and adults present with? Are they different?
They can be.
Yeah.
Children might strongly express wanting to be the opposite sex, ask for different names or pronouns. Now, while many kids might show these traits,
Doesn't always persist.
right, only a small percentage continue into adulthood, though more intense childhood symptoms seem linked to persistence. Teenagers and adults might also verbalize this desire very clearly, dress as their affirmed gender, and often seek medical interventions like hormones or surgery to align their bodies with their identity.
And their sexual orientation.
It's important to understand they typically don't identify as homosexual in relation to their birth sex. For example, a biological female who transitions to male and loves a woman identifies as a man who loves a woman. It aligns with their affirmed gender.
What about epidemiology and comorbidities? What should nurses know?
Gender dysphoria itself is actually extremely uncommon, very low prevalence rates. But comorbidities are important to watch for. Children might also have anxiety, disruptive behaviors, depression, maybe autism spectrum disorder.
And older individuals.
Adolescents and adults commonly experience anxiety and mood disorders. Substance use can be an issue, sometimes self-destructive behaviors too, which just underscores the profound need for comprehensive mental health support from nurses.
What about risk factors? Biological, psychosocial?
Well, biology isn't seen as causative, but it influences development. Hormonal imbalances like atypical testosterone levels have been noted. There's also a suggested genetic link studies show higher rates in identical twins.
And the psychosocial side.
Theories there include things like maybe the absence of a same-sex role model growing up, or perhaps parental approval, even subtle, of cross-gender identification. It's generally seen as a complex interplay of factors.
So how do nurses provide care? How do we guide individuals through what can be a really challenging journey?
A key nursing diagnosis might be disturbed personal identity, reflecting that incongruence between their expressed and assigned gender. The desired outcomes focus on the patient finding social support, developing healthy coping skills, and ultimately accepting their own sexual identity, whatever that journey looks like for them.
So the nursing role is very supportive.
Very much so. Supportive therapy, creating that safe space, helping patients manage the significant social and emotional hurdles they often face, discrimination, misunderstanding, family issues.
The source mentions several advanced interventions. Can you walk us through the different therapeutic and medical approaches?
Sure. First, psychotherapy. For kids, there's actually no single consensus on the best approach. Goals might range from optimizing their overall adjustment to supporting their exploration of a cross-gender identity or maybe helping the child accept their natal gender. It depends.
And for teens and adults?
For them, long-term individual and family therapy is often recommended. Developing coping skills for potential harassment is key. And before any medical transition, a thorough psychological evaluation is standard practice.
Okay, then the medical side. Pharmacological.
Yes, adolescents might receive puberty blockers. This is a reversible approach, which is important. It basically pauses puberty, buying time for more exploration before permanent physical changes happen.
And for adult?
Adults might choose hormone therapy. Testosterone for female-to-male individuals leading to things like muscle gain, facial hair, voice deepening, or estrogen for male-to-female individuals resulting in less body hair, fat redistribution to hips, maybe some breast growth.
And then surgical options. Sex reassignment surgery.
Yes, or gender-affirming surgery. This is an option usually reserved for severe, intractable dysphoria. It involves really extensive preparation.
Like what?
Living full-time in the affirmed gender role at work, school, socially. Making legal adjustments like name changes. Physical prep like electrolysis for hair removal. Only after hormone therapy might surgical procedures follow, like reshaping genitals or removing reproductive organs to align the body with identity.
It sounds incredibly complex, truly life-altering. The source mentions a study on regret rates after surgery, but also a very famous tragic case.
Yes, the Swedish study found a very low regret rate, around 2%, suggesting high overall satisfaction with surgical outcomes.
But the counterpoint,
The tragic David Reimer case. He was a male identical twin whose penis was destroyed in a childhood accident. He was surgically reassigned and raised as a girl. But despite intense psychological support, he never felt right, never identified as female.
and the outcome.
He later lived as a male, but tragically died by suicide. His story is often cited as illustrating the profound biological influence on gender identity. It really underscores the complexities, the need for incredibly thorough preparation, and the importance of ongoing support, even after surgery. Psychotherapy is still needed post-op for adjustment and sexual functioning.
Okay, our final segment dives into paraphilic disorders. This is a category often misunderstood, definitely highly sensitive. How are these defined clinically?
Right. Paraphilic disorders involve sexual fantasies or behaviors that are considered atypical by society. But the key is, for these individuals, these specific fantasies or behaviors are required to experience desire, arousal, or orgasm.
But it's more than just having the fantasy.
Yes. To be a disorder, it has to cause significant distress or impairment in their life, or pose a persistent risk or actual danger to themselves or others. And these patterns need to be present for at least 6 months.
And an important point the book makes.
Crucially, many people who might technically meet the criteria based on their fantasies do not actually act on those sexual feelings, especially if they could harm others. That's a vital distinction.
Okay. Can we quickly run through some of the specific disorders mentioned, just to give listeners a sense of the range?
Sure. There's exhibitionistic disorder, intentionally displaying genitals in public, mostly men exposing themselves to women. The arousal comes from the observer's shock or reaction. Fetishistic disorder, sexual focus on inanimate objects closely tied to the body, shoes, gloves, stockings, things like that. Frotteuristic disorder, rubbing or touching a non-consenting person, usually in crowded public places like subways. Pedophilic disorder, a predominant intense sexual interest in prepubescent children, typically 13 or younger. The diagnosis requires the perpetrator be at least 16 and at least 5 years older than the child.
Okay, what else? Sexual sadism and masochism disorder. Sadism is getting sexual satisfaction from causing physical or psychological suffering. Masochism is deriving it from being humiliated, beaten, or made to suffer. These often involve consenting partners, and usually actual serious harm is avoided. Transvestic disorder, getting sexual satisfaction from dressing in opposite gender clothing. This is different from gender dysphoria. There's no desire for sex change, and individuals are usually heterosexual. Voyeuristic disorder, seeking arousal by secretly watching others in private situations undressing, having sex, often starts in adolescence, can be chronic.
Mm-hmm.
And there's a catch-all category, too.
Yes. Paraphilic disorder not otherwise specified. This covers other specific fixations not listed, like obscene phone calls, attraction to corpses, animals, feces, enemas, urine, or even oxygen deprivation during orgasm. The key for nurses is just understanding the broad spectrum and, importantly, the potential for harm or distress involved in some of these.
The chapter also brings up a really important advocacy point connected to pedophilic disorder: the push to eliminate statutes of limitations for reporting childhood sexual abuse.
Yes, and this is where nurses can truly be advocates. Victims often delay reporting, sometimes for years, even decades. Old statutes of limitations can literally prevent perpetrators from ever being stopped or brought to justice.
And high-profile cases have brought attention.
Exactly. They've fueled activism to challenge these laws. Many states are now looking at increasing or eliminating those reporting windows. It's a clear example of how patient advocacy and social responsibility directly intersect with nursing practice. We have a voice.
What about epidemiology, comorbidity, risk factors for paraphilic disorders in general?
Well, they're generally uncommon in the population, but the behaviors can be repetitive. They mostly affect Caucasian males, often with onset before age 18.
Do the behaviors change over time?
They tend to peak between ages 15 and 25 and often decrease by age 50. Comorbidities are common. ADHD, substance abuse, major depression are frequently seen. Substance abuse in particular is strongly linked with sex offenses.
And risk factors.
Biological influences might include things like frontal lobe damage from head trauma, which can affect impulse control. Psychosocial theories range from psychoanalytic ideas about early development to cognitive theories suggesting distorted thoughts make deviant behaviors seem okay or justified.
Okay, let's turn to the nursing process. Assessment. How do nurses even approach this, given that patients rarely come in saying, I have a paraphilic disorder?
That's exactly right. They rarely enter care specifically for the paraphilia. You're more likely to encounter them in general psychiatric settings because of those comorbidities, depression with suicidal thoughts, substance use treatment, or, of course, in forensic settings due to legal issues.
So the focus is broader.
Yes. You need to assess for potential self-harm or harm to others. Focus on the patient's presenting problem, the depression, the substance use, but also try to understand their perception of how the sexual disorder impacts their current illness or situation.
And nurse self-assessment again.
Absolutely vital here. These behaviors can evoke really strong negative reactions in healthcare providers: disgust, frustration, anger. It's essential to be aware of those feelings, to differentiate between a victim and a perpetrator in your mind, and critically, to seek support from colleagues or faculty if you find yourself really distressed by a case. You need to maintain professionalism.
Okay. Diagnosis, outcomes, planning.
Diagnoses might include things like risk for suicide, risk for other directed violence, or ineffective impulse control. Outcomes focus squarely on maintaining safety for the patient and others controlling impulses, and hopefully improving interpersonal relationships. Planning always prioritizes safety and crisis intervention, especially if hospitalization is needed.
And for implementation, what are the core nursing interventions?
Providing a non-judgmental presence is huge, even if difficult. Exploring underlying identity and self-esteem issues can be helpful. Encouraging optimal functioning in other areas of life. Inconsistent limit setting is absolutely key, especially for individuals who might violate others' boundaries on a unit.
Health teaching, too.
Yes, focusing on reducing those comorbid symptoms like depression and anxiety. Also, helping patients identify the triggers for their pathological behavior. What situations or feelings lead up to acting out?
And teamwork on the unit.
Paramount. Patients with these disorders often isolate themselves. Encouraging group participation can be tough, but it's a vital opportunity for them to practice social skills, maybe develop some empathy, start seeing others as real people with feelings.
What about pharmacological interventions? Are there meds used?
Yes, primarily two classes. First, anti-androgens like medroxyprogesterone acetate, MPA or Depo-Provera. These reduce testosterone levels and libido. They're sometimes used for high-drive offenders like those with pedophilia or exhibitionism.
And the second class?
SSRIs, the antidepressants like fluoxetine, used off-label here. They can help improve mood, reduce impulsivity, decrease those obsessive sexual thoughts, and sometimes, paradoxically, they cause sexual dysfunction as a side effect, which can be therapeutically useful in this context.
And advanced practice interventions?
Primarily cognitive behavioral therapy, CBT. Helping patients learn new, more appropriate sexual response patterns, maybe using positive reinforcement for good choices, or sometimes aversion techniques under controlled conditions. Psychodynamic therapy might explore the origins, and of course, advanced practice nurses can get specialized training and credentialing in sex therapy through organizations like AISECT.
Lastly, how do we evaluate care for individuals with paraphilic disorders?
Evaluation criteria focus on safety. Has the safety of the patient and others been maintained? Have the behaviors causing distress and shame reduced? Have interpersonal relationships improved? Treatment is often long-term, focused on reducing recidivism that relapse into offending behavior. Outro.
And that brings us to the close of another deep dive. Wow, what a profound journey into aspects of human sexuality that really require both clinical expertise and just deep empathy.
Indeed. Understanding sexual dysfunction, gender dysphoria, and paraphilic disorders, from the assessment right through to interventions and all the ethical considerations, it's truly foundational for you as future mental health nurses.
Yeah.
You're building knowledge, yes, but maybe more importantly, you're cultivating that empathy, that non-judgmental approach. That's just essential for truly patient-centered care.
So what does this all mean for you as you continue your nursing studies, prepare for your careers? It means every single patient has a story. And often that story includes these deeply personal aspects of their sexuality that impact their overall health and well-being. Your role is to be that knowledgeable, compassionate guide.
Absolutely. From the entire Last Minute Lecture team, thank you so much for joining us on this deep dive. Keep asking questions, keep learning. And remember, you're not just building knowledge banks, you're building empathy as you become the skilled and compassionate mental health professionals of tomorrow.
So true.
And maybe a final thought to leave you with. What surprising insights did you gain today about the silent struggles many face regarding sexuality? And how might that shape your approach to patient care, maybe even beyond these specific topics we discussed? Something to think about.